Welcome to Omega Matters. This is our little show where my dad and I have casual conversations about health and nutrition, research statistics, and of course, omega-3 fatty acids. I'm Christina Harris-Jackson. I'm the Director of Research at Omega Quant Analytics. We're a clinical lab that specializes in fatty acid analysis, and I'm a nutritional science researcher and a registered dietitian. And I'm here with my dad, of course, Bill Harris, who is a world-renowned scientist in the field of nutrition, specifically in the realm of omega-3 fatty acids, and has recently started a nonprofit called the Fatty Acid Research Institute, or FARI for short. He did start Omega Quant Analytics over 10 years ago to be able to offer to clinicians omega-3 index testing, which is a biomarker of omega-3 intake and related to risk for cardiovascular disease. And he developed the omega-3 index with his colleague Clemens von Schacke in about 2004. And recently, he has been ranked in the top 2% of scientists in the world based on impact in his publications. So that was exciting news. Today, we're joined by Dr. James O'Keefe, who's another giant in his own field. He's a preventive cardiologist and director at the Dubach Cardio Health and Wellness Center and the director of preventative cardiology at St. Luke's of Kansas City Mid-America Heart Institute. Dr. O'Keefe did his medical training at the University of North Dakota, his home state, and his internal medicine residency and cardiology fellowship at the Mayo Clinic, so Midwestern. He's listed as one of America's most influential doctors by USA Today and is on the Sirius XM show Dr. Radio regularly. He's also been on Dr. Pete Atia's podcast, given several TED Talks, written several books, and also founded a nutraceutical company with his wife called CardioTabs, who is also a dietitian. So today we're going to talk to Dr. O'Keefe about omega-3s in the clinic and whatever else comes up. So thank you for joining us, Dr.
Yeah, my pleasure, Christina. It's great to be here with you and Bill. You know, Bill and I have been friends for decades, and it's kind of fun because it is not an exaggeration to say everybody in the world knows when we talk about the cod father, as in COD, cod father of the omega-3 story, it's Dr. Bill Harris. So it's a really fun thing to see.
Yeah, I wish I'd made that up. I stole it from somebody, but anyway.
Yeah. You do have the omega-3 license plate in South Dakota, though. So that's
really? Wow. Okay, that's fun. Yeah. Mm-hmm. Yeah, I've been trying to talk him into coming back, move back to Kansas City. I actually lured him away. One time when he was at the University of Kansas, I lured him over to St. Luke's Mid-America Heart Institute to work with us and do research. And we collaborated on a bunch of projects, including some omega-3. One omega-3 study that I think is still really relevant to us, a randomized placebo-controlled trial where we took a relatively small number of people and randomized them to, I think it was just 1 gram per day, as I recall, Bill, and looked at, looked at indices of autonomic fitness. So we looked at like beat to beat variability and peak exercise heart rate and resting heart rate. And you know, it showed that omega-3 lowered resting heart rate by like 3 to 4 beats per minute. And so anyway, it's yeah, we've been friends and collaborators for a long time.
Yeah, what was cool about that study, I think we also did that in heart transplant patients, right, that are denervated. And we saw that lowered heart rate even in people without nerves to the heart, which is pretty amazing.
Right.
Yeah.
Which which is hard to explain, really. I mean,
it is hard to explain. Don't have to explain everything. We just make observations.
Right.
Yeah.
So that was one of my first questions, is kind of asking how you guys met, started collaborating, have a history together. Do you remember your initial, where you first
I think I was at KU in the mid-90s when James was, he was a cardiologist at St. Luke's Hospital, still is. And we just got to be friends because of our interest in omega-3s. And he found a way to create a endowed chair for me and then lure me over to St. Luke's UMKC. And it was a fantastic change for me. I really appreciated it.
Yeah, Ben McAllister, the late great Ben McAllister, helped us with that, and
Sure.
and it was I think we had met at some conferences, you know, that we were speaking at or something like that. But yeah, we hit it off right away, and Ben been good friends ever since.
Excellent. Well, Dr. O'Keefe, how did you originally get interested in omega-3s in the world of preventative cardiology?
I mean, it's just such a organic, natural connection. It's if you look through the history of the omega-3 story, like in the 1960s, Jorn Dyerberg and his colleagues he was a MD PhD who was doing some research over in Greenland and studying the Greenland Eskimos, which, Greenland has been sort of a, like a part of the Danish Empire in the remote past. And so they had this connection and went over there. They were studying the Greenland Eskimos and comparing them to the Danes, who eat a lot of fish on their own, but they noticed some striking differences in their fatty acid profiles. And they saw this stuff, EPA, DHA, they hadn't seen before. And then they theorized that this came from fish and that this was the reason why that they saw very little to no coronary heart disease or atherosclerosis in general in these Eskimos, Inuit. So then when I was in medical school in the early 80s, the late 70s, early 80s, there was this school of thought, being a nutritionist and a dietitian, Christina, you relate to this, that that fat was bad for you, and that the ideal diet, was the Pritikin diet and the old American Heart Association diet. And there's still the Ornish diet that's still there, trying to convince us that all fat is evil. And, so I kind of, being an impressionable medical student, I started following that diet and I realized this is not working for me. I was getting skinnier and I was weak, and my triglycerides were always normal. Suddenly they were high, and my HDL went down, and I thought, this is not right. So I started looking into diet, and it became obvious that one fat for sure that was good for you was omega-3, even at that early stages in the 80s, and then some studies came out, and it's actually an interesting sort of historical point in my life that when the Je suis Prevention study came out in like 1998, and this was 1 gram of an ethyl ester mixture of EPA and DHA that provided about 850 milligrams of EPA DHA, one tablet. And they were pretty sure, Bill, that was just one capsule, right, Bill? Yeah. And it was 11,000 people, Italians, who had just survived a heart attack, myocardial infarction, and they were randomized to this or not. And it showed this really robust, like 25% reduction in the primary endpoint, which was major adverse cardiovascular events, including cardiovascular mortality. And I just thought, wow, this is really impressive. It's just like a mega trial with a simple little nutrient. And so I started, recommending it for my patients, and I realized, omega-3, like, you can't just generalize it. So I decided, my fellow Brian Curtis back then was complaining about this as we were sending our patients to, go get omega-3. And they come back with all sorts of, usually kind of the standard, 30% EPA, DHA, 120, 180. And so he suggested maybe we should start a company that makes a high quality, markets a high quality omega-3. So that's what we founded CardioTabs about 1999. And that's been sort of our centerpiece, is to have a real good, highly purified, concentrated omega-3, and it's also a great excuse for me to go to Norway or Copenhagen or Iceland, or about once a year I go over there, and through a lot of the connections that Bill introduced me to, a lot of the luminaries in the omega-3 sort of folklore, history, and smart scientists, and it's fun to interact with them, and that's also fun to be able to to choose and find what I think are the best omega-3 products to offer for our customers and patients.
Yeah, that's a really good point about clinically using omega-3s. And what do you tell people? And first thing I get asked all the time is, what should I take? And I'm just like, it depends. And it's really excellent that you know exactly what you can recommend, what's in it. And it just makes it so much easier, because there's so many products and they're changing all the time. And it becomes very hard to counsel people through that maze of supplements. So that's great.
Yeah, and Christina, it kind of fits in with the mission statement and vision of the Omega Quant, is that these decades of research, what we're finding is that dose really matters. And of course, the dose is not the only thing, but it's probably the major factor in determining how much omega-3 you have in your cell membranes, like the RBCs. But the latest data would really suggest, that dose matters, and so you need to get enough omega-3, and maybe as little as 500 milligrams of EPA DHA will protect you from fatal myocardial infarctions, like these unstable rhythms, VT, VF, that sort of thing. But for the broader range of cardiovascular health, like things like reducing risk of myocardial infarction or revascularization or total coronary heart disease events, or even stroke, ischemic stroke, it seems like a higher dose is better. And then it really matters, to be able to find a product that's concentrated. And of course, it always helps to have a compliant patient. As you know, getting people to take their fish oil can involve some arm twisting.
Yeah. And that's one thing I really like with testing, is to be able to show people what you're taking is actually getting into your body, or not, if they're not taking a good product. And so it's that just motivation and proof, I think is really powerful.
It's one of the fundamental axioms of economics is the first step in changing anything is measuring it, or the first step in managing something is measuring it. And
right.
So that's where I think that, getting that Omega Quant, because people, my wife, Joan, who's like you, a smart dietitian, she says, oh, I hear this all the time. People say, oh yeah, I like fish. Yeah, I like fish. And then they find out how often they eat it. Well, like twice a month, and then it's like, some fried catfish or something that doesn't have any omega-3 in it. So it is really pretty much a epidemic, sort of like that. I don't know, you guys would know better than me, but I would bet 90% of Americans don't have an ideal, an omega index in the ideal range.
95.
95%. Yeah.
And it's even, our estimate is that the average omega-3 index in the US and Canada actually did a true representative sampling of their population and measured the omega-3 index, and their average was 4.5%. So like 50% ish of people are below 4, which is really rare. Yeah,
if you're thinking ideal would be 8 to 11, right? Mm-hmm. Then is that what you'd call ideal?
Yeah. 8 to 12, yeah, basically.
8 to 12.
Over 8 is the biggest.
8 to 8.
Right.
And the Japanese would have about the average mean in the Japanese would be 8 or
9 or 10.
Oh, no.
Koreans are around 9 or 10 too.
Mm-hmm.
South Koreans.
Yeah.
And maybe no coincidence, these are among the longest lived people in the world. I don't know about Icelanders, if you have them, but they also have a pretty remarkable longevity. Now it's a pretty tight genome there on the island of Iceland, and they have a lot of other good sort of healthy habits, but I bet their omega index is pretty high too.
Yeah. So you had mentioned the JISI trial, and we've had more very large trials come out since then, obviously, and there's been some mixed results. We've had VITAL and REDUCE IT and STRENGTH all fairly recently. How do you take those studies, and how does it affect how you think about omega-3s with your patients? I'm sure you don't describe all these studies to your patients, but how do you see these studies in the landscape or not? What context do you put them in, kind of more generally?
So, as you know, Christina, the gold standard in sort of scientific evidence is randomized placebo-controlled trials. But lots of times they're done on, variable populations with variable doses and all sorts of other sort of differences that make them not necessarily generalizable. So if you can put together a bundle, like the entire experience of randomized placebo-controlled trials and do a good meta-analysis on it, that's really the gold standard of medical and scientific evidence. And so, and this is such a frustrating field, the omega-3. I don't know, like, I know you guys feel it too, but physicians, and I'll just apologize, off the bat, physicians tend to have sort of like the expert syndrome where, just because they went to school till they're 32, they think anything health, even though they don't know much about it, they'll give you their opinion and tell you that that's the final word. And there's nowhere more sort of incomplete in our knowledge base than nutrition. I mean, like, I went to school till I was 32 to become a cardiologist, which, arguably nutrition is among the very most important determinants of cardiovascular health. And I got not a single hour of lecture on nutrition. I mean, it's crazy, and it's still like that. But then people ask, and like you see the advertisements, whatever, ask your doctor about whether this. So doctors, because they have no nutritional training, tend to be very skeptical about anything nutrition. I mean, how important could it be if they never taught us anything about it? It's like, sure, we could, diet can help, but nobody follows it. So, and the omega-3 thing, because there's these, some studies are positive, some studies are negative. They tend to be skeptical anyway. So doctors have really done a disservice to the science, in my opinion, because they're always telling, my partners and, people are always telling them, oh, omega-3 is not important. I mean, omega-3 is so important. It's like, especially when 95% of people aren't taking it. And so get back to like the gold standard, Aldo Bernasconi, who's at the Intermountain Heart Center in Utah, is a very bright PhD, and he worked with Chip Levy and several other people. Bill, were you on that study as well, that meta-analysis that came out recently? But anyway, it was a meta-analysis, included all the data, including like the strength data, which had the fatty acids unesterified, and it was 4 grams of EPA plus DHA, and all these other, randomized trials that were sort of nominally called negative, but if you look closely, there are several endpoints where they're positive, even with low doses. And then, of course, the home run Reduce It trial, which used the EPA ethyl ester at 4 grams, that showed the 25% reduction in heart attack, stroke, and cardiac death. But all going all the way back to the Je suis prevention. And so there's 150,000 people in this meta-analysis. And sure enough, they saw a 35% reduction in fatal MI, so highly statistically significant, a reduction in coronary heart disease events, and I believe stroke. But in any event, these were highly statistically significant reductions, and this was a dose-dependent thing. So, it trended to it's not real precise, but the trend is that as you go from 500 to 1,000 to 2,000 to 4,000 milligrams per day of EPA plus DHA, you see more significant benefits. And that they, interestingly, in that study, which kind of fits with my perspective, is that you couldn't say for sure whether EPA was better than DHA or not. Most of the trials use some mixture, and when you put that all into a complex, really well done meta-analysis, it looks like a mix is as fine as. And from my perspective, I'd love to hear Bill's thoughts on this. And it's still an open question, but I really believe that since if you if you look at most fish and seafood, it's a mixture, maybe a 50-50 mixture in that, and it varies from one species to the next, of EPA plus DHA. And this is what we're meant to eat, and this is what we have been eating. And so, like, these are really important compounds, and they do have somewhat, subtly different actions. But I kind of feel like a mixture is ideal because you get the anti-inflammatory effects from both. But for getting the DHA into the cell membranes, that's mostly a DHA function. So for brain and eyes, I think that needs to be in the mix, and most experts would would agree with that. But the EPA thing is also important as well. So Bill, what's your idea? What's your thoughts on that?
Well, I would have said the same thing, that this is what we're designed for, EPA plus DHA. They both play a role. You get the resolvins and protectants from the two different molecules, these, of course, the oxylipins, they're very highly anti-inflammatory. And so I think you need both. It's fine to show that EPA works, and reduce it appears to have shown that. Love to see a DHA only trial, but I don't know that that's coming. But when it comes down to just, day to day, what do you recommend to people? I think you've got to have both of them.
Right. And is it safe to say that of the two, the one that the DHA has a more sort of milligram per milligram effect on raising your omega index than EPA?
Yeah, yeah, it does. Right, and whether that means it's better or not is another question, but it does have a different impact, but slightly. It's partly because when you give DHA, EPA levels tend to go up too. But when you give EPA, DHA levels don't go up. So anyway,
Right.
In the membrane.
In many ways, they're sort of complementary. In my perspective, they do. I said they have subtly different properties, and they're complementary, which is sort of no coincidence, since, as you say, we're sort of designed to be eating both together.
Yeah, yeah. So do you recommend most of your patients be on omega-3? Is that just, how do you do that?
So when this topic comes up, as it does with most of my patients, I always, make sure to, give them full disclosure that, I started a supplement company called CardioTaz, but I do pay close attention to the literature, and I always ask them, how much fish and seafood do you eat? Because if they're like a typical Japanese person, they're eating fish twice a day and their omega index is 9 or 10, it's like, no, and they have normal triglycerides, I would say, you're good. I mean, this is a super important nutrient and you're doing great with it. But almost always people tell me that they eat fish, once a week, or they hate fish, or whatever. And then I say, okay. And then I look at their triglycerides, and you've published a lot of this, the most important research on this, but for sure we know that there's a dose-dependent benefit for lowering triglycerides, and triglycerides are sort of coming into their own now. And this is, one of the blood parameters that we look at as an atherogenic protein, lipoprotein in the blood, and all the other agents that we've used for triglycerides, like the fibrates, even though they lower triglycerides significantly, have not been shown definitively to improve cardiovascular prognosis. Whereas I think that was the most important message from the Reduce It, is these are people that had triglycerides above 135. I think it was 7,000 people, and had either coronary heart disease or diabetes with other risk factors. And it showed that when you gave them 4 grams of EPA and lowered triglycerides, I think it was about 20%, that you did see this substantial reduction. And the people that did the study kind of made the point that it wasn't all due to triglyceride lowering, but you could also look at the people who had significant, like triglycerides above 200 versus below 200. They had a more significant benefit if they had high triglycerides at baseline. I mean, I think it's the best evidence ever for a triglyceride lowering compound for improving cardiovascular prognosis. But getting back to your question, so if their triglycerides are high, like above 150, I use 4 grams of EPA plus DHA, and then if they're say above, well, I mean, for most people, I would like to get them on 2 grams of EPA plus DHA per day. In our cardio wellness center, we have a cardiometabolic center. These are people with diabetes or prediabetes, lots of times with heart disease. And those folks, in the vast majority of them, will have the atherogenic lipoproteins, with the high triglycerides and low HDL. So I think it becomes a pretty standard thing for me to recommend that. I always tell them to take it with food because it's better absorbed. And then I also, a lot of these people end up, actually the science and medicine of optimizing people's lipid profile from a, diet, from a medication and supplement standpoint is pretty simple now. I mean, if your LDL is high, statins, ezetimibe and PCSK9 inhibitors all do different things. They have a synergistic effect, like 1 + 1 + 1 = 6. And they all have event reduction capabilities. They reduce heart attack, stroke, cardiovascular death, and they're complementary. They really work well together. So I use one or more of those, enough to get their LDL to the goal. For a lot of people, it's less than 70, and it almost always gets there. And then for triglyceride, which is, I think, another different parameter, I mean, I use omega-3, and then a strong statin will help with omega-3, with triglycerides as well. So I get them on, a good like rosuvastatin or atorvastatin, and the higher dose is better for triglycerides. And then you use a good dose of EPA plus DHA, and those are, not only do they work well for optimizing, excuse me, not only do they work well for optimizing the triglycerides and the LDL, but they also optimize the long-term risk, the risk profile.
Mm-hmm.
Yeah.
And kind of the other end of a lot of the omega-3 work that we do, we look at long-term risk and blood levels and predicting that. Then people ask a lot, what can you notice in the shorter term if you are at a low omega-3 status and you go to a higher status by taking 2+ grams? Do you have any experiences with people who started very low and then progressively took omega-3s, had higher status, and had other like more subtle changes in their health?
Yeah, I think that I think that it's very real, the sort of sense of omega brightening effect on your mood. Artist Simopoulos has been writing about this for decades, but your brain is 60% fat. By if you exclude the water weight, it's 60% of the brain is fat, and its preferred fat is omega-3. And the brain tends to work better. It's less inflamed. Mood is better. A lot of people notice that it really does have an effect. My wife Joan is really on a mission. She thinks everybody in the country should be on enough omega-3 to get their omega index into a good range, because mental health is such a huge growing problem in America. And like when she sees these mass shootings or something like that, she says, I would love to know what his omega index is. And I think she makes a good point that you don't know what your what your sort of baseline function is until you get those levels up to normal, so that your neurons, the cell membranes in the neurons are uninflamed and highly communicative and being as responsive as they should be. I mean, it's a simple thing. There's really no downside to it. So I think that that a lot of perceptive people will notice, and it doesn't happen overnight, but I would say in a matter of a few weeks of supplementation, a lot of people notice that their mood is better and their cognition is just sharper.
How about joint pain?
Oh, there's no question about that too. There's one sort of interesting way to look at to take the placebo effect out of things is to figure out what the vets are recommending for their patients' dogs and cats. And for instance, like they'll say, oh yeah, get them on omega-3 supplement. That oftentimes will help with the arthritic joints and whatnot. And it does. It reduces inflammation. So a lot of people, or post-workout muscle soreness, even in younger athletes. But certainly it reduces musculoskeletal inflammation, whether it's due to osteoarthritis or rheumatoid arthritis or just wear and tear from a heavy workout.
Yeah, it's the kind of day-to-day things that if you can start, you kind of have to be mindful enough to notice it at some point sometimes, because then you'll look back and be like, oh, I do feel better in these cases. And that helps motivate to continue to take it and feel those effects, because it's hard to just say, oh, this is 30 years, you won't have a heart attack. You need like some shorter time frames, at least, especially with like younger people, if we're working with younger people, just more immediate body functioning. And then there's also like the heart rate variability that you guys started with, and then we just published another paper kind of on that topic, and just helping your heart function better, even as a young person, as an athlete, it helps with the whole system. So
that's where I get really frustrated, because I know that this makes a big difference. And then when people hear these mixed messages, then they say, oh yeah, I used to take omega-3, but I heard, my doctor told me it's not important, so I don't take that anymore. One of the things that we fight against in prevention in general, which in my opinion is the most important, it's like it should be the foundation of health activities, because it's just so much better to prevent a stroke or a heart attack, or not to mention Alzheimer's disease, or all these stuff, depression, suicide. I mean, this stuff is very preventable. But once it starts kind of, sort of developing into a disease process, it gets much messier, much more expensive and less pleasant. Not to mention, in the meanwhile, it may have ruined or ended your life. But the tricky thing about that is that, we put people on omega-3, for example, and then they come back the next year and they've been taking their omega-3, and they don't say, and by the way, thanks so much for preventing that stroke I would have had. They just assume they're healthy because of course they're healthy, of course they'd be healthy, but, and each one of us is our own uncontrolled lifelong experiment, and we're just bumbling along, and so that's why you have to look at these giant studies and extrapolate to your own life, and then do the intelligent thing to keep you, to just stack your odds in the right direction for staying healthy. But even when you do that, you sort of take for granted that, it's all just, luck or genetics or whatever. I mean, most people they just totally take their health for granted. So they assume that they never would have had a heart attack or a stroke or Alzheimer's or whatever.
Right.
And that's where, as healthcare providers and educators, I feel like it's my mission to kind of, to tell people, this is very much in your control. Some of it's not in your control, but if you use the latest science and stack these things out, like nutrition and sleep and social support and tracking your blood pressure and your lipids and your other health parameters. I mean, and it's just a golden age for that, right? And it's only going to continue with all the wearables. I mean, you can drive yourself a little crazy, with all the different Fitbit and Apple Watch, but I think if you collect those data and focus on the important things, and I would say omega-3 is among the most important things from a nutrition standpoint to really focus on, it makes a huge difference. And not just in, your longevity and all those far off sort of risks that you may or may not come down with, but just as you were sort of intimating, Christina, just your day-to-day sense of well-being. I think it makes a big difference. Yeah,
I do too. It has for me, I think. Do you have anything else that you'd like to chat about? We probably should wrap up here, but
I want to hear your thoughts about Afib.
Oh, yes.
Oh, right. Well, that kind of sort of circles back to what we were talking about at the beginning, Bill, that study I did 20 years ago that showed it did improve beat-to-beat variability and augmented vagal tone and slowed resting heart rate. And those are good things. Those are all parameters that tend to correlate pretty strongly with good cardiovascular prognosis. So, and they're also, if you take a young, healthy athlete or a teenager, I mean, they have you tell them to take slow, deep breaths while you're listening to their heart, and it goes boom, boom, boom. This phasic, with every breath, their heart rate slows down and speeds up like an accordion. I mean, it's pretty interesting to look at, but this is a marker of a healthy cardiovascular system. But so AFib is like a lot of conditions. It's a very multifactorial thing, and some people have a bradycardia dependent. Like some people with sleep apnea get this excess of vagal tone and they get bradycardia, and then that increases the refractory period it increases the time it takes to depolarize after a heartbeat. And so it can make it more vulnerable as the heart rate slows down and the vagal tone goes up. It can make it more vulnerable to AFib. So like in the REDUCE-IT study, AFib rates went up from 2% in the placebo population to 3% in the folks that got the 4 grams of EPA. And so this was like a 50% relative risk increase. But at the same time, stroke went down 29% in that study. So it does. I think if you do a big meta-analysis, I think you'll find a dose-dependent increase, modest increase, but probably significant increase in AFib. But it doesn't. But I think overall, it still tends to be beneficial. And in those people, hopefully those aren't the same people who have triglycerides of 400, where you need to use 4 grams. I mean, I think 1 gram per day, you probably would not have much of an increased risk of AFib, and you'd still get, like the reduction in fatal heart attack. Heart attack risk. So what do you think?
Risk benefit. Yeah. I mean, I'm not an expert in AFib by any means, but you're right. The absolute change, the absolute effect in those trials was quite small.
Right.
Going from 2% of people to 3% of people. It gets magnified when you do relative risk reduction, relative increase.
Right.
But yeah, I mean, your point about people who have very high triglycerides, you need 4 grams a day. So would you then talk to them a little bit more about AFib, or think more about AFib in them? Are there other risk factors that they need to consider in recommending that dose in those people?
Yeah, I mean, in fact, we just have a paper that we're just sending in this week. So the paper is about how to prevent AFib with lifestyle and dietary modifications, which now we just think about, antiarrhythmic drugs, which are potentially toxic, and catheter ablations, which have, you go in and burn parts of the left atrium to try to make the AFib go away. Turns out that AFib, which is quite prevalent. I mean, 1 out of 4 people over age 40 will get AFib in their lifetime, and it does increase risk of stroke. And it's highly modifiable, that risk, with things like treating sleep apnea, weight loss, alcohol. I mean, the previous generations of cardiologists called AFib holiday heart syndrome, because people would show up, New Year's Day or the day after 4th of July with AFib. So, and tobacco, too much exercise. There's a lot of modifiable things, but so the omega-3 is a bit, we're still trying to figure that out, but I would think in those people, there's a lot of ways you can reduce risk of AFib. I mean, if they need their omega-3, which most people do, I would use lower doses, and maybe somebody who's really got that sort of a heart rate, a resting heart rate of 50 or 60 beats per minute, who has high triglycerides, I might think about using fibrates in that person, but it doesn't really affect my sort of vast, my general pattern about how to prescribe omega-3 for my patients.
Great.
Excellent. Yeah, I think there's going to be some meta-analyses coming out on the AFib question this year. So it sounds like, so that'll be good.
Yeah, I think, Bill, didn't you say you're working with some folks in the ferry
Force
platform?
Codes. Yeah, right.
Force, yeah. Okay.
Starting to work on one. So that'll be interesting.
Mm-hmm.
All right.
Good.
Well, we probably should wrap up here. Thank you so much for talking with us, Dr. O'Keefe. It's just great to hear someone talk about using omega-3s in the real world, and knowing everything about the research too. So thanks so much.
Thanks, James.
Well, it's my pleasure. And as I mentioned before, I love to collaborate with Bill, and we're always sort of strategizing about other things we can look at. But this is it's definitely a personal and professional passion, omega-3, and keep up the great work there at Omega Quant.
Thank you.
Thanks.
Have a great day.
Bye.
Okay, you too. Bye-bye.